In the last three classes, we talked about the pathology, clinical presentation, and management of the most common types of lower extremity wounds. We talked about arterial wounds, venous wounds, and neuropathic wounds. And we mentioned that there are wounds that are caused by other pathologies. That's the focus of this class. When you look at a patient with a lower extremity wound, your first goal always is to identify the etiologic factor and to address either that factor or factors. Sometimes it's more than one. So you go back to what do we know? We know that the majority of leg ulcers are going to be caused by the big three: venous disease, arterial disease, neuropathic disease, or possibly some combination of those. But a significant minority are caused by other disease processes. And it's always critical to start with identifying and correcting causative factors for any wound. So what does that mean for us? There's a lot of disease processes out there that can cause lower extremity wounds. Do we have to know them all? No. But what we do have to do is use our basic critical thinking processes and critical thinking skills. We always have to do a complete basic assessment. So we want to look at the patient's history. We want to be particularly alert to risk factors for arterial disease, venous disease, and neuropathic disease. We want to do a vascular assessment so we know, is there adequate perfusion to the extremity? Is there any evidence of venous insufficiency? We want to pay a lot of attention to the pain history. How severe is the pain? What makes the pain better? What makes the pain worse? And as we go through some of the atypical ulcers, you'll see that pain is a very common presenting factor, so we'll come back to that. And then we want to look at ulcer location and characteristics. Then basically what we're doing is looking to see, does our data create a match to arterial ulcers, to venous ulcers, to neuropathic ulcers? For example, what if I have a patient who is obese, has a sedentary lifestyle, has a history of deep vein thrombosis, presents with an ulcer on the medial malleolus and with 2+ edema? On vascular assessment, feet are warm, pulses are palpable, positive hair growth, no elevational pallor, no dependent rubor, ABI within normal limits. Ulcer located on the medial malleolus, as I said, ruddy ulcer base, large volume exudate. The patient reports aching pain that is worse at the end of the day and relieved with elevation. So now we can say, okay, now does that match any of the big three? Is that consistent with arterial disease? No, it's not consistent with arterial disease. Vascular assessment indicates normal perfusion. Location of the wound is not consistent with vascular disease. Appearance of the wound is not consistent with arterial disease. And pain pattern is not consistent with arterial disease. What about venous disease? So we have positive risk factors. The patient's obese, the patient's sedentary, the patient has a history of DVT. Our vascular assessment rules out arterial disease as a causative or contributing factor and points toward venous disease because we have 2+ edema. The pain pattern is consistent with venous disease. Pain that's worse at the end of the day and relieved by elevation. The wound characteristics are consistent with venous disease. Location, medial malleolus, ruddy ulcer bed, large volume exudate. So I can proceed to establish a management plan based on venous insufficiency. But what if, when I look at my patient history, when I look at my vascular data, when I look at the pain pattern, when I look at the ulcer characteristics, it's not a match to venous disease, It's not a match to arterial disease, and it's not a match to neuropathic disease. In that case, I'm dealing with an atypical lower extremity wound. And in addition to initiating appropriate topical therapy, I need to initiate a referral to either vascular or dermatology to help me determine what's causing this wound and what needs to be done about the causative factors. Now we're going to talk about some of the most common causes of atypical ulcers, but you want to realize this is not exhaustive. There are other conditions out there. So your big challenge is to conduct a comprehensive assessment and then look to see, is it a match for arterial? Is it a match for venous? Is it a match for neuropathic? If the answer is no, you start reaching out for assistance and identifying what's causing the wound. Now we're going to talk about vasculitic ulcers. There's a lot of conditions that can result in vasculitis, and inflammation of the blood vessels, or in vasculopathy, damage to the blood vessels. So we're going to talk about vasculitis, but just know that patients may also present with warfarin necrosis, that's a vasculopathy, or other conditions that adversely affect the health of the blood vessels. Vasculitis, as the term suggests, involves inflammation of the blood vessels, frequently progressing to necrosis in patchy areas of the vessel. Typically affects small and mid-sized vessels on both the arterial and venous side of the capillary bed. Who gets vasculitis and why? Well, in most situations, it's associated with some kind of autoimmune condition, sometimes with a drug reaction, occasionally with a malignancy, sometimes with infection. They think that what happens, especially with the drug reaction and with some of the autoimmune disorders, is that you get an antigen-antibody reaction. And then these little antigen-antibody complexes attach to the vessel wall. When those antigen-antibody complexes attach to the vessel wall, it causes release of enzymatic substances that trigger an acute inflammatory response involving the blood vessel. When you get acute inflammation of the blood vessel, when you get damage to the vessel wall, because you can actually get significant damage to the vessel wall, then you can either end up with vessel occlusion because the inflammation causes so much edema that the vessel literally becomes closed. Or sometimes that enzymatic damage and the inflammatory response creates a perforation in the vessel wall and blood leaks out into the surrounding tissue. So you can get one of two patterns. You can get a picture of acute ischemic damage if the antigen antibody reaction, deposition, inflammation causes vessel occlusion, or you can get perforation of the vessel with leakage into the surrounding tissues. So when you look at this, these are just a couple of slides of vasculitic ulcers. I want you at this point to particularly focus on the one on top where there's clearly something going on with the blood vessels because you have this petechial type rash. It looks like blood's leaking out into the tissues, and it is. So what would make me think I might be dealing with a vasculitic ulcer? What would the clinical presentation be? Of course, it's going to be variable. It's going to depend on which vessels are involved. It's going to depend on the severity of the inflammatory response. And it's going to depend on whether or not the acute inflammation results in vessel occlusion or if it causes a perforation in the vessel with leakage into the surrounding tissue. Most of the time, the ulcers are located on the lower extremities, very commonly on the anterior surface of the leg, but sometimes around the malleoli. Notice the ulcers are usually full thickness, so they're not superficial. They go all the way through the epidermis, dermis, into the subcutaneous tissue, and sometimes deeper. Notice they're extremely painful. The ulcer bed is typically pale or necrotic because remember, this acute inflammation involving the vessel wall typically results in occlusion of the vessel or so much damage to the vessel that you get perforation. So the surrounding tissue frequently is ischemic. Not surprising that the ulcer bed is frequently pale or necrotic. Usually minimal exudate, again, that goes along with not much blood flow. And the ulcer edges are usually well demarcated. Ulcers are relatively shallow, most of the time, but sometimes deep. Now, in some ways, that sounds like an arterial wound, doesn't it? Pain, pale or necrotic wound base, minimal exudate, well demarcated wound edges. But when you go to do the vascular assessment, what you're going to find out is that you have warm feet, good pulses. If you're able to do an ABI, a normal ABI, positive hair growth. You'll also find that the pain pattern doesn't really match arterial ulcers because with an arterial ulcer, typically the patient will tell you that the pain is diminished or relieved by rest and dependency. And the patient with a vasculitic ulcer will tell you it doesn't matter what position their leg is in or what they're doing. They're in acute pain. Also, you have symptoms with vasculitic ulcers that you do not have with arterial ulcers. You have this petechial rash or purpuric rash, which you see in several of the slides. That rash can precede the ulcer, or sometimes it's seen concurrently with the ulcer, so you might have a central area of ulceration and the petechial or purpuric rash all around the ulcer. In addition, remember that vasculitic ulcers are commonly associated with autoimmune conditions. So many patients will present with systemic symptoms in addition to the lower extremity ulcers. So they might complain of fatigue, malaise, joint pain, those kinds of things. Okay, so let's say I have a patient, I'm like, well, I don't know, the patient's in a lot of pain. In some ways the ulcer looks like an arterial ulcer, but the location doesn't match. The pain pattern doesn't match because it's not relieved by dependency and rest. Patient feels bad in general, has all this joint pain. There's this petechial rash around it that doesn't look like it matches an arterial ulcer. I'm just not sure. I'm going to initiate a consult. I'm going to ask dermatology or vascular to see this patient and to help me determine etiologic factors. So clinical presentations suggest to you that there's something else going on, that it's not classic arterial disease, venous disease, or neuropathic disease. You initiate a consult. They're first going to do lab studies. They're going to look for indicators of significant systemic inflammation, so they'll be looking at SED rate, at ANA, other inflammatory markers. They may also do a biopsy, both within the wound and at the periphery of the wound, to see if they can capture a section of the blood vessel and if it shows damage. What about management? Now, our role is to provide topical therapy. The reason we need dermatology or vascular on board is so that they can help us determine the underlying pathology and treat that. If it's an autoimmune condition, they're going to treat typically with systemic anti-inflammatory agents. If they think it's a drug reaction, they're going to eliminate the offending drug, that kind of thing. So a lot of these patients will end up on steroids or other anti-inflammatory agents. If they have a very severe condition, they may do plasmapheresis because that removes those little antigen antibody complexes that are attached to the vessel wall and triggering the inflammatory response. And here's where we come in. Moist wound healing, but a big focus on pain management. And sometimes that's the most important thing we can do for the patient, is to say to the physician, how are we going to manage his pain, her pain? I'll give you an example. I had a patient just last weekend. They consulted me to see the patient. And initially the thought among the team was, among the medical team, was that this was probably a venous ulcer. That's why they consulted us. Why did they think that? Because it was located on the medial malleolus. However, there was minimal edema. The ulcer bed looked pale as opposed to ruddy. The patient's overwhelming complaint was pain, severe pain. When I asked her what made the pain better or worse, she said, nothing makes it better. The only thing that makes it better is pain medicine, and it only makes it a little bit better. It doesn't matter whether my leg is up or down, whether I'm in the bed, up walking around, I'm in terrible pain all the time. I initially applied in a foam dressing that has anti-inflammatory effects and is sometimes associated with reduced pain. I got called back to the room. She's like, I can't tolerate that, it's too heavy. What we ended up doing, in addition to obtaining a dermatology consult, was we ended up putting lidocaine gel onto the wound bed, and then a very simple non-adherent gauze and wrap gauze. Actually, we didn't use non-adherent plastic gauze, we used a silicone adhesive contact layer. So we did the lidocaine gel, we did Mepitel, we did gauze and wrap gauze to give her at least partial pain relief until we could get dermatology involved and appropriate systemic pain management. So if we see a wound that looks as if it might be a vasculitic ulcer, what are our major responsibilities? Initiate a consult so that the underlying condition can be identified and treated. Assure adequate attention to pain management, and continue with moist wound healing. Pyoderma gangrenosum is another type of inflammatory wound that is acutely painful. Now, the big difference between pyoderma gangrenosum and your vasculitic ulcers involve inflammation affecting the blood vessels. Pyoderma gangrenosum involves an acute and chronic inflammatory process that targets the dermis and the subcutaneous tissue. If you break it down, pyoderma, you end up with purulent drainage, dermal destruction. So pyoderma gangrenosum, gangrene or necrosis of the dermis, and purulent drainage. Most patients with pyoderma have some other type of chronic inflammatory condition. The two most common, inflammatory bowel disease or rheumatoid arthritis. But that's not always true. There's a subset of patients who present with pyoderma gangrenosum, and they have no inflammatory bowel disease and no arthritis and no other autoimmune process. So most have another autoimmune condition, but not all. How do these lesions present? Well, these are all very common presentations for pyoderma gangrenosum. Most commonly, you end up with full-thickness ulcers, craters. They may have kind of purplish borders, but not always. Sometimes you'll have pustular lesions, but more often they're crater-type lesions. Very common to have necrotic tissue, so you can have some mix of necrotic tissue and viable tissue. They're typically exudative. They result in deep dermal destruction and scarring. And in patients who have had pyodermal lesions, you'll frequently see scars all over their lower extremities. Again, acutely painful. That's one of the hallmarks of pyoderma gangrenosum. It's also one of the hallmarks of vasculitic ulcers, the level of pain. So when you walk in and the patient is telling you that their pain score is 15 out of 10, and that nothing makes it better except sometimes medication, you know that you have an atypical wound. You know that something else is going on. You know you need someone else to help. Two things that are significant with pyoderma: pathergy and recurrence. What is pathergy? Pathergy means that minor trauma triggers a major flare. So an example would be, what if I came in and I took a scalpel or a curette to remove that slough from the wound surface? So I'm trying to clean up the wound, but in so doing, I'm traumatizing the wound surface. I might come back and find that the patient's pain level is much worse and that there's marked extension of the ulcerative process. These wounds tend to extend. You might start with one, then you might have two or three. You might start with a small one that becomes much larger. So whenever we're putting together a management plan, one of our goals is to minimize trauma, to use dressings that provide for atraumatic removal, to avoid any kind of instrumental debridement, to avoid things like wet to dry, to make sure the patient knows no scrubbing, all of those kinds of things. Here's the other bad news about pyoderma: recurrence is very common. So you'll work very hard to get this wound to heal, to give this patient pain relief, to help this patient get back into their life. And then 6 months later, or 12 months later, they might be right back with another wound. We have a lot left to learn about pyoderma gangrenosum, how to prevent it, how to most effectively manage it, how to prevent recurrence. At this point, about all we can do is treat each wound appropriately as it arises. How do we diagnose pyoderma? Well, many times you and I are the first ones to suspect pyoderma. We'll go in, we'll be talking to the patient, they're telling us how painful the wound is. We can quickly identify, well, this doesn't match a venous ulcer. If you look at the wound on the far right, it's on the medial malleolus, but that's the only characteristic that matches a venous ulcer. The patient doesn't have significant edema. The pain is unrelenting and constant. It is not relieved by rest. It's not relieved by elevation. The depth of the wound is inconsistent with venous. Venous ulcers do not develop necrotic tissue, or very rarely develop necrotic tissue, and necrotic tissue is a very common hallmark of pyoderma. So you're like, okay, well, the location matches venous, but nothing else matches venous. That tells me it's not a venous ulcer. Something else is going on. So critical responsibility for us: go in, do the assessment, recognize when what we're seeing and what we're hearing does not match venous or arterial or neuropathic. Get other clinicians on board. Now, I've heard many physicians say, well, they never diagnose pyoderma. Pyoderma is a diagnosis of exclusion. If you do a culture, it's going to be nonspecific. If you do a biopsy, which is the most commonly done diagnostic procedure, it's going to show acute and chronic inflammation. It's not going to say pyoderma. It's just going to say acute and chronic inflammation, which you know is consistent with pyoderma. So you want to realize it is a diagnosis of exclusion. What the patient wants to know is, how do we treat it? How do we get it better? how do you get me some degree of pain control so that I can get back to my life? What's the pathology? Inflammation. So we have to treat with anti-inflammatory drugs. And this is kind of a double-edged sword when we're trying to get a wound to heal. So we think, well, if we put the patient on high-dose steroids, that's going to slow the repair process. And that's true, but remember that goal number one in managing any wound is to interrupt the cycle of injury. Identify the causative factors, address those causative factors. So we have to start with anti-inflammatory medication. That could be steroids, it could be anti-TNF drugs like Remicade or Humira. Doxycycline has anti-inflammatory effects and is sometimes used off-label. Cyclosporin is sometimes used. Lots of different anti-inflammatories that can be used. Sometimes they'll do intralesional steroids. Sometimes they'll do a combination of anti-TNF drugs given IV and maybe a topical anti-inflammatory. But the first thing we have to do, we have to get that inflammatory process under control. We have to break the cycle of injury so that the ulcer starts to contract down. And even though we know that healing will be slower because we have the patient on potent anti-inflammatories, we have to do that because step number one in management of any wound is correct causative factors. If we can get pain management for this patient, they can manage the slower healing. What makes these wounds unbearable is the level of pain. So advocating for the patient, making sure that other members on the team know how painful these wounds are, suggesting things like lidoderm patches adjacent to the wound, making sure the patient's on an appropriate pain regimen around the clock, suggesting referral to a pain management group if the primary care provider doesn't feel comfortable providing pain relief. It's not okay just to say, well, I don't feel comfortable, writing a prescription for opioids for wound pain. Okay, if you don't feel comfortable, who are we going to refer the patient to? Because pain is the most disabling aspect of this wound. So either we're going to provide pain management or we have to refer the patient somewhere. Never acceptable to ignore pain management. Okay, so then it comes down to us to initiate topical therapy. Our goals are manage the exudate, keep the wound surface moist, prevent trauma because we don't want to make anything worse. So here are things that are commonly used. A lot of clinicians will use a silicone adhesive contact layer because you can put that down and you can leave it in place for 7 days. You can irrigate the wound through it. You can apply gauze and wrap gauze over it and change the outer layer's PRM without disrupting the primary wound bed. That can be so helpful to the patient. So think about a silicone adhesive contact layer plus gauze and wrap gauze. Think about topical lidocaine. Think about lidoderm patches. Now the other thing you should know is that there are anecdotal reports that some of your antimicrobial dressings can reduce inflammation and may help reduce pain. So the one that comes up more often than anything else is hydrophoroblu. And that, of course, is your PVA foam that's impregnated with methylene blue and crystal violet. So you can always think about, let me put down the silicone adhesive contact layer, and let me put this foam on top and secure it with wrap gauze and see if that makes a difference in the patient. It will manage the exudate, it will prevent pathogen, and it will provide some antimicrobial and anti-inflammatory effects. The other topical agent that is sometimes effective is topical tacrolimus. or protoping. Again, you're going to work with the patient to try to find a solution that works for them. Most of the time you'll be working with other members of the healthcare team. Sometimes you have to advocate for the patient and say, we're not controlling his pain adequately. We have to revisit this. I was recently consulted on a patient who had actually gone to a wound center, and because the wounds began at the medial malleolus, the physician in the wound center was confident it was a venous ulcer and wanted to manage with compression. But none of the patient's history was a really good match for venous. He was overweight, he didn't have DVT, he wasn't really sedentary, and his pain pattern did not match at all. His pain pattern was 10 out of 10 unaffected by limb position or activity. In addition, when they initiated compression therapy, he immediately removed it because he said it was way too painful. He could not tolerate it. And the ulcers clearly demonstrated pathergy because when anybody did any aggressive cleansing, the wound rapidly expanded. They did conservative debridement in the wound center, massive expansion of the wound. So many clinical indicators of pyoderma. When we suggested that pyoderma might be the pathology, the etiologic factor for this wound, they asked a researcher from dermatology to look at it. The researcher says it doesn't look like pyoderma to me. That's all the researcher said, doesn't look like pyoderma to me. Based on that, the physician in the wound center ruled out pyoderma and insisted to the patient that this was a venous ulcer. The reason he was not getting well was he would not be compliant with compression therapy. His wife was a nurse. His wife had worked with our wound team many, many years, and she said, please look at my husband. I feel like he's going to end up with bilateral amputations. If that's what has to happen to get him out of pain, that's what has to happen, but I just want to make sure I'm not missing anything. We looked at him and we were like, this is not venous. And his wife said, well, I don't know. My background's neurology, but in the wound center, the doctor said it was venous. Like, our team was confident it was not venous. We're like, you need a second opinion. And if you can't get it here, we'll find someone who can do it for you. So she did. She went and got a second opinion, another dermatologist who listened to his history, evaluated him carefully, had seen the many phases of pyoderma clinically, and agreed with our team, yes, this is pyoderma. He's got to be treated with anti-inflammatories. Started him on cyclosporin, and we have very gradually seen marked improvement in his wounds. They got much worse before they got better because of misdiagnosis. And I share that story because sometimes people think, well, the patient's being seen in a wound center. Just because they're being seen in a wound center doesn't necessarily mean that the wound physician has a lot of experience with vasculitic ulcers, with pyoderma. So sometimes you have to say, ask for a second opinion. Trust your knowledge base and your ability to listen to patients. Okay, back on track, sorry. Sickle cell ulcers. A lot of you will work with patients with sickle cell disease, sickle cell anemia. You know that sickle cell anemia is characterized by abnormally shaped strands of hemoglobin. And those abnormal strands of hemoglobin, they're elongated and they're stiff. And they tend to change the shape of the normal red blood cell. So a normal red blood cell looks like a donut with no hole in the middle. And a normal red blood cell is very flexible and able to adapt to the contours of the vessel and to move through narrow vessels out to the tissues. So you see normal red blood cells on top. But when you have these abnormally shaped strands of hemoglobin, they tend to cause a sickle shape to the cells, and they make the cells stiff, so it makes it hard for the cells to move through narrow vessels. During periods of crisis, these abnormally shaped cells tend to clump together and occlude the vessel and cause acute tissue ischemia. That can occur out in the soft tissues and create ulcerations. It can occur within the joints and trigger severe pain, can cause damage in the eyes. So this sickling effect, this clumping effect, can cause multi-organ damage. We're dealing with ulcers that result from episodes of acute tissue ischemia. The other thing you have to be aware of, which I didn't put on the slide, but whereas normal red blood cells with normal hemoglobin can live for as long as 90 to 120 days, sickle cells with the abnormally shaped hemoglobin typically survive only 10 to 20 days. So that helps explain why these patients are chronically anemic, chronically fatigued. So what have we got? Well, we have got essentially an ischemic wound that was caused by an acute occlusive episode. Following that acute occlusive episode, typically blood flow returns to almost normal, and hopefully will be sufficient to support wound healing. Here's the other thing that occurs though. You get edema because patients with sickle cell disease lose the normal vasoconstrictive response. So remember we talked about the fact that a normal arteriole, a normal artery, has the ability to dilate to provide increased volumes of blood flow when you're up and active and your metabolic needs go up, and also has the ability to narrow and partially constrict when you're at rest. Patients with sickle cell disease lose that ability to constrict, so their vessels are chronically dilated, and that contributes to edema. As a result, many of them will end up needing compression therapy. How do sickle cell ulcers present? They're almost always located on the distal 1/3 of the leg. Sometimes anterior, sometimes medial, sometimes lateral. The edges are usually well-defined, sharply demarcated. There's usually very little drainage. They're very slow to heal. They're very prone to recurrence because of the underlying disease process. And again, they're acutely painful. Pain is a hallmark of sickle cell disease. And during crisis episodes, pain is one of the patient's greatest issues and concerns. So how do we diagnose a sickle cell ulcer? If I know that that patient has a diagnosis of sickle cell disease, sickle cell anemia, and they have an ulcer on the lower extremity that matches the characteristics, that is a pretty clear diagnosis. So it's almost always based on history and physical. There's not a single diagnostic test. It's just looking at the characteristics of the ulcer, seeing that it's consistent with an acute occlusive episode in a patient who has sickle cell disease and who has sickle cell crisis preceding the ulcer. So this is what they look like. They look very much like some of your arterial ulcers, although location is different. Standard arterial ulcers are going to occur distally, the points furthest from the heart, or in areas of trauma or pressure injury that fail to heal. In contrast, sickle cell ulcers occur in the tissues that were affected by the acute occlusive episode. So it can be anywhere in the lower extremity. It's just which vessel became occluded and which tissues were affected by that vessel occlusion. We're going to do topical therapy following the basic guidelines. Keep the surface moist, meaning you're exudate. What else needs to be done? Well, we want to try to prevent further occlusive episodes. How do you do that? First of all, hydration. Hydration is critical to patients with sickle cell anemia because we've got to reduce blood viscosity, keep the blood flowing. So making sure that the patient understands how critical hydration is. Working with the patient every day to make sure they're getting adequate fluid intake. We want to treat any infection. Infection can trigger a crisis. We want to provide nutritional support for wound healing. They may be placed on hydroxyurea, and the reason they may be placed on hydroxyurea is because it increases the ratio of normal hemoglobin to abnormal hemoglobin. So increases normal and reduces the volume of abnormal. And if the patient's acutely anemic, they will require blood transfusion, which in turn will support healing. What about malignant lesions? Now, we don't see a lot of these, but remember that a lot of your skin cancers occur in areas of the body that were exposed to the sun, either repetitively or excessively. And that's usually face, arms, legs. So, basal cell carcinoma, squamous cell carcinoma, potential causative factors for lower extremity lesions and wounds. So we're going to look first at basal cell carcinoma, which of course is a malignancy involving the basal membrane of the epidermis, those reproductive epidermal cells. It can develop as a primary lesion, or it can develop in a chronic wound over time as a result of persistent recurrent inflammation. If it develops in a chronic wound, it's commonly known as a Marjolin's ulcer. How does it present? Marjolin's ulcers, the ones that occur in chronic wounds, frequently present as hypergranulation tissue that does not respond to cauterization. So you might see that presentation. More commonly it presents as red-pink nodules like you see on the top. Or you might have a central area of ulceration with rolled pink edges all the way around, and the edges will be raised. So those are the classic clinical presentations. Here's the bottom line. If I see a wound and I'm like, I don't know what that is, that certainly is not consistent with a venous ulcer, a neuropathic ulcer, an arterial ulcer. I want to make sure I'm not missing a malignancy. It is never, ever wrong to request dermatology input and to get a biopsy. Because if it is a malignancy, we want it treated. Basal cell carcinoma, squamous cell carcinoma, very treatable. We just have to identify it. So, moving ahead to squamous cell carcinoma, again, superficial skin cancer. It involves the keratinocytes. It occurs in areas that were exposed to the sun repetitively. So again, most common on the face, neck, ears, scalp, arms, and sometimes the legs. And these are the different presentations. So you could have an indurated papule or nodule, which is what you see on the right, where you have the ulcerated center sitting in the middle of a nodule that is somewhat indurated. You can have crusted areas, which you see in the center. Or sometimes you'll have a shallow lesion with raised edges all the way around. So those three presentations, very classic, very common. And again, what's your responsibility? Just recognize that's not your standard ulcer. There's something else going on here. Let's get that biopsy. So sometimes patients will come to you and they'll say, you're the skincare nurse. You're the wound care nurse. What do you think this is? Family members, patients, friends. You're like, I'm not sure, but it doesn't look like a classic ulcer, and you're telling me it just came up, it just developed, and you've used all these ointments and it hasn't gone away. It's painless. I want you to see the dermatologist and let the dermatologist do a biopsy, and he or she will tell you if you need to have anything else done. One of the most painful lesions is that caused by calciphylaxis. Some of you have seen these patients. They probably make you want to cry. They make me want to cry. So what is calciphylaxis? It fortunately is rare, is potentially fatal. It involves calcium deposits within the walls of the blood vessels, which of course reduces blood flow and causes tissue necrosis. And it also involves calcium deposits out in the soft tissues. It's also known as calcific small vessel ischemic disease. Most of us do not call it that. It's most often seen in patients who have end-stage renal disease. Typically they're on dialysis. Many times they're diabetic. Why? What causes this? What's the pathology? What makes them start depositing calcium out of the tissues or depositing calcium within the vessel wall? There's two major theories regarding pathology. One is that there's some kind of hypercoagulability that leads to calcium precipitation. The other is that there's a sensitivity reaction that causes calcium to essentially move out of the bloodstream into the tissues, into the vessel wall. What we see clinically, these patients have elevated calcium levels, they have elevated phosphorus levels, sometimes they have elevated parathormone levels. So you think, parathormone, isn't that the parathyroid hormone? Yes. And what's its job? To regulate calcium and phosphorus levels. So a small subset of patients with calciphylaxis do have parathyroid disorder and might benefit from parathyroid resection. That's not true of the majority. What does calciphylaxis look like? How do these lesions present? They typically start as painful mottled lesions. So if you look at the slide on top, I think you can see some mottling right around the edges of these necrotic wounds, because those mottled painful lesions progress to necrotic nodules and ulcerations. And it usually involves areas where there's a lot of soft tissue, fatty tissue. So you'll see it on the lower extremities. You can also see it on the breast. You can see it on the abdomen. You can see it in the buttocks. In general, when we see patients who have trunk lesions, they seem to have a worse prognosis than patients whose wounds are confined to the lower extremities. I haven't seen a study on that, but I have heard that in podium presentations, and I've certainly seen it clinically. Acutely painful. The patient's biggest concern, get my pain under control. So that should be our biggest concern as well. Look at the mortality rate, 50 to 80%. And the factors that lead to death are either overwhelming sepsis or vascular damage because of calcium deposits in the blood vessels. So if you get significant interference with blood flow to the kidneys, significant interference with blood flow to the heart, you can see that the end result can be fatal. Who's likely to get it? Women are higher risk than men. Your obese patients are higher risk than people of normal weight. And most of your patients will be diabetic, on renal failure, on dialysis. Okay, I think it's calciphylaxis, just looking at the way it presents and the way it progresses. So history and physical suggest that this patient is in stage renal disease, is on dialysis, does have these painful necrotic mottled areas. So workup would then involve lab values, looking at calcium levels, looking at phosphorus levels, looking at parathormone levels. And And they can do a bone scan and see, where do you have calcium deposits? Do you have calcium deposits in your vessels? Do you have calcium deposits in your soft tissues? That's pretty much diagnostic for calciphylaxis. The patient wants to know, how do you treat it? And most importantly, how do you relieve the pain? So you want to do everything possible to stop calcium deposits in the vessels and in the soft tissues. You want to normalize calcium and phosphorus levels. You can do that partly by diet, to some extent with medications that bind calcium and phosphorus. And they can also look at the dialysis solution, the dialysate, and use a solution that pulls off more calcium. So many measures are put into place to normalize calcium and phosphorus levels. In some centers, they'll do sodium thiosulfate infusions because sodium thiosulfate can help to mobilize calcium deposits and help block further calcium deposits. So you might see your patient placed on sodium thiosulfate. Pain management of critical importance, we keep saying that, but if you have one of these acutely painful wounds, that matters more to you than anything else. Pain management is much more important to you than getting the wound to heal. But you're going to have to make decisions about topical therapy. When the patient comes in, they're in acute pain, everything's unstable. If they have dry necrotic wounds, it's best to just leave them open to air unless they're acutely infected. Because at this point, you're not going to make much headway in managing the wound until we correct the underlying pathology. So if they have dry necrotic uninfected wounds, leave them alone. Get your systemic management plan into place, which is going to involve diet, meds, dialysis, modifications. Get your pain management established. Then once the patient is stable systemically, you can move ahead with active treatment of the wounds, which typically involves debridement, ideally under anesthesia. These patients usually cannot tolerate debridement at the bedside. Most of the time it does require surgical debridement because most of the time they have extensive wounds. So surgical debridement under anesthesia, negative pressure wound therapy, and then grafting. That's what it usually takes to heal these wounds, and that's what you see in the slides to the right. And then the last one we're going to mention, necrobiosis lipoidica diabeticorum, and most people just call that NLD for obvious reasons. You're very unlikely to see this. It's a very rare condition associated with hyperglycemia and diabetes. We don't even know what the pathology is. We don't know what the risk factors are. The way it presents is you get these very well demarcated kind of waxy looking lesions. So they have kind of a shiny, waxy appearance. It's usually on the anterior and lateral surfaces of the leg. The plaques can vary in color. Sometimes they're yellowish, sometimes they're kind of brown, sometimes they're kind of red. For a lot of patients, they're not painful, they're just ugly. I've had people say, what are these and what can I do? They're ugly, I can't wear my shorts or I don't want to wear my shorts. But some patients do report pain. How do we diagnose it? Just by history and clinical presentation. There's not a diagnostic procedure at this point in time. More importantly, how do we treat it? Sometimes they'll give them systemic or intralesional steroids. The problem is, if you don't know the pathology, if we don't know what causes it, it's very hard to treat it effectively. So most of the time, we do nothing except watch it. Occasionally, patients will develop shallow ulcers in the middle of these waxy plaques. And if they do develop shallow ulcers, we just follow the principles of moist wound healing. So this is another condition where we have a lot left to learn. So in summary, As you know, effective management of any wound requires accurate identification of the causative factors and measures to correct those causative factors. We will never, as WOC nurses, will never know everything that's out there, and we don't have to. Here's what we have to do. We have to have good critical thinking skills. We have to do an appropriate assessment. So we have to look at what's the patient's medical surgical history. How did this wound develop? What's the pain pattern? What does my vascular assessment tell me? Do I have adequate perfusion, or do I have signs and symptoms of ischemic disease? Do I have signs and symptoms of venous insufficiency? Is this wound located on the foot in an area exposed to repetitive trauma and therefore consistent with neuropathy? I want to take my data. I want to compare it to the typical data for an arterial ulcer. Is it a match or a close match? No. Venous? No. Neuropathic? No. Then I get help. So I don't have to know everything that's out there. I just have to think through my data. And I have to be aware when a wound does not match one of the big three. And then I have to seek help. I never worry about people who say, I'm so worried about my ability to be a good WOC nurse, I don't think I'll ever know enough. I don't worry about them at all. So if you're one of them, I'm not worried about you. You'll be great because you'll constantly know what you know and you'll know what you don't know and you'll reach out for help. People worry me when they're like, I've got this. I'm like, really? Because every day I'm faced with things that I'm like, what is that? What should I be doing here? Who should I consult? Critical thinking means you look at your data, you determine whether your data is a good match for a condition that you're prepared to treat. And if it is, you proceed. If your data is not a good match for a condition you're prepared to treat, you seek help. And that's the bottom line. Know what you know what you don't know, never hesitate to ask for help. And that's the end of this presentation. Thank you.